My name is Martin Isaksson. I'm a chiropractor from Sweden. I'm going to talk about the Olympic Games in Rio 2016 a bit. I'm going to share a couple of different perspectives of how my time there was and what we got up to, and a couple of interesting things that I really learned from that big, huge event. And it's a pleasure here to have Christine Foss with me today as well. So we're going to go through a pretty cool road of what we did during the games, and I look forward to having this webinar with you. All right, so if we head to slide 2, the next page, this is just a little bit about me, what I've done so far. I worked at about 20 plus world championships and multiple national ones. As I said, I worked at the Rio Olympics in the IOC polyclinic, World Games. I'm the founder of the Swedish Chiropractic Sports Council. I'm also the European rep, what we call the sits on the board as Executive Council. And I just recently got elected to the second vice president of FICS. I teach the FICS chiropractic modules, and I'm also the medical director of RockTep Scandinavia. So I've done a few things ever since I got out of university, but you know, it's all about getting your way through and fighting, and you know, if you want something really bad, you will get there. All right, so let's get to the presentation outline on the next slide. First, we're going to talk a little bit about Olympic Village. I'm then going to head into the polyclinic and a little bit how chiropractic fits in, how to be a team player. And also, we're going to finish off with a pretty interesting case that took me on a pretty big journey. And I learned a lot from that case, especially in terms of how to work with maybe athletes that come from a very different background and are in the games, maybe not just only for joy and happiness, but also there for making sure that their family is provided for. So it definitely is a different way of thinking in terms of that. All right, so if we head into Olympic Village, which is on the next slide. Now, transportation was interesting. So as you can see there on the picture on the right-hand side, it took quite a long time to get to the Olympic Village every morning. Considering that we started at 6 o'clock in the morning, and then you're going to add in buses to get to the Olympic Village on that, which was an easy 1.5 hour ride. And in Brazil, I got to say, they might not always be on time. Sometimes they were early and sometimes they were late. It was a little bit mañana, but it was early mornings, I got to tell you. It was getting home late sometimes and up at 4 o'clock in the morning. So that could be pretty tough. Our home base was at the Barra de Chujica. I'm probably pronouncing that completely wrong. But so we had an apartment where a few of us stayed, chiropractors. I slept literally on the floor on just a mattress. Just to find space. It wasn't the important thing. It was just a means to an end. So that's what I did, and I'm happy as Larry anyways. It didn't really matter. The language, I gotta say, is I mean, Portuguese, nothing like Spanish. Sure, you could probably get by a little bit better than I could with English, but most people do not speak a word English. Even the people in the polyclinic, in terms of the locals, hardly spoke any English. So it was tough at times to understand, and especially when first few days when we're going to change buses at certain stations, and you're like, okay, so I'm going here, and he's like, No English. All right. So you had to figure some stuff out. I think we went wrong a few times, which was all right. Yeah, it was an interesting couple of first days. On the next slide, we'll talk about a little bit more about the polyclinic, which was a 3,200 square meter clinic. It was absolutely huge. And I gotta say, I mean, you walked in and you had a lot of different professions in there, but it was like huge, big tents almost. And next one, you will see that you had 2 MRIs. You can just continue, Christine. You had 2 CTs, you had 4 X-rays, you had diagnostic ultrasound. Most of the things that you actually needed in terms of imaging was there. If we go to the next slide, we'll see that you had a lot of different professions. So you had 3 to 4 sports MDs, physicians every shift. And I wrote in there, get to know them and adjust them, because it's super important that you come off in the good end, kind of. They are definitely hesitant to chiropractors, a lot of them, or most of them, but by just being simply humble and talk to them every morning when I walk by or walk past their offices, I made sure to say hello and good morning. And a lot of them were from different parts of the world anyway. If I had the chance to eat lunch at the same time as they do, I made sure to sit down and talk to them. And that's literally how you bridge these gaps in between the professions. So it took me about 3 days before I literally had the first MD coming into the polyclinic and getting adjusted. And for her, it was a complete eye-opener. She had aches and pains for a long time in different parts of her body. After a couple of treatments, she was so much better. After that, she started to send a lot of athletes my way because they had to go through the MDs first before they could come into the polyclinic, specifically the physios and the chiros and osteos. So it was imperative that you got a chance to literally get to know the MDs, because they were that's where the buck stops. So I was from the reason I made sure to pay my every morning and so forth, making sure that they know who I were. And it paid off. I was after about 3 days, I was full every shift. And a lot of times it was because they sent their patients into me. So it was super. We also obviously had 2 to 4 radiologists on shift every shift I was there. 10 to 15 physios, 2 sports chiros. So I worked a lot with Ulrich Sandström when I was there, which was awesome. We had so much fun, and 2 osteos, and the osteos were super as well. A lot of times we just got to, everyone got a chance to work on athletes, and we talked between the tables, and it was so it's a lot of fun. Sure, there was a specific room for chiros and a specific room for osteos, but I got to say, I don't think I treated more than maybe 1 or 2 patients in there during my whole 2 weeks, because you want to be in where everyone else are. Mostly because you want to make sure that everyone understands chiropractic and understands what we do. A lot of times I think we take for granted that most people know what we do. And I got to say, most of the time, it's actually the opposites. Especially I see this when we go out on events and wherever we are in the world doing FICS events. Most of the time, even the coaches doesn't know what we do. So, but being open and being transparent in our how we talk and making sure that we are inclusive in our talk makes them really, really happy. Especially, I mean, both me and Ulrich a lot of times had physios that literally walked around with us to different patients to see what we were doing, because they were so intrigued. Like, can you do that? I had that question for a couple of times, which was just brilliant. And that bridge you can create by doing that is far greater than any letter or anything else you can do for to get in contact with whomever. If they can see what you're doing and they see that you're not a lunatic and you're actually treating patients for who they are and what they want and so forth, it's the best thing you can do, definitely. If we then head to the next slide, obviously we had a lot of dentistry, we had a lot of general surgery, there was pharmacy, there was orthotic place you can get orthotics and like almost everything. There was a massage therapist on duty every day, a rehab gym, an ice bath. The picture is pretty cool because it's literally a treadmill where you fill it up with air, so you feel like you're running in the air. Literally, it becomes almost like a vacuum. And it was pretty cool that you could take away all that pressure and stress on an athlete and still have them running. So they might come in with any form of ligament or whatever, and you really wanted them to do slow rehab back and making sure that you didn't load those joints too much, or you didn't load the extremities too much, whatever that was. Then you could have them running on this treadmill. They could still move, but it was so light, so you felt like a featherweight in there, which is pretty cool. So that was a pretty much, I've never seen them before, so it was a little bit of a highlight there for me. But other than that, it was literally full on. I mean, dentistry is always the most used utility in Olympic Games every time, and there were lines of people waiting for that. So, and I don't know actually how many they had on staff, but it was incredible the amount of dentists that was ongoing. So that was pretty cool. On the next slide, we talk about, so we had obviously 2 chiros, the patient intake process, which is pretty cool. As I said, you got most of your patients from the MD. If sometimes the patient or the athlete just came strictly straight into the polyclinic to our treatment area, and if they hadn't gone through the proper channels by going to the MD first, what you had to do then is take them to the MD and talk about, okay, is this something that you feel okay with me taking on? So it was literally their choice to select that. Unless they've already been there before, obviously, and they just want continuous treatment, that was fine. And sometimes you actually got patients or athletes from the physios. If you got to know them quite well and they respected you and they thought that you was a good asset to the team, they would actually send the patient your way, which is kind of nice. Especially when I say be mindful of other professional knowledge, it's easy to assume that we as chiropractors would fix everything in that room, anything that walks into those doors. And I mean, we do take care of a lot of athletes and we do it really well. But I think also it's very important to acknowledge that a lot of those physios wouldn't be there unless they've actually pretty good at what they're doing. And they've been selected for these games. So a lot of times, both me and a couple of other chiros, like Ulrich and Tim Stark, we would include the other professions in our care. So I might start working on this patient athlete's shoulder or whatever they came in for. And then after, when I was done, excuse me, I would literally send them over to the physio. Hey, could you do maybe some stim or some soft tissue stuff or whatever, just to try to bridge in between the professions and try to work with everyone. I mean, in the beginning, they were like, "Oh, well, it's your patient. Yeah, I mean, I don't need to do this." And you would like, "Well, I think it's good. I think the patient needs to feel help from more professions than one, and they need. I mean, we're a team. We need to work as a team because we are a team." And by talking in that way, I think we can be more or less on the strong side here and show the good things about why we are chiropractors and literally appreciate how much we know, and then use other professions and to the help or the benefit of the patient or athlete. On the picture you see to the right was 4 of us chiros. So David Stevenson from Australia, Camilla Björnsen from Norway, me, and then Masahiro Goto, which is from Japan. And underneath that picture we had, it was me and 2 osteos, and the rest were physios. So you can see there was a fair bit of physios every shift. We weren't too many of the chiros or osteos. Next picture is literally talking about understanding the hierarchy. So by understanding that we are not top of the food chain when it comes to Olympic Games, and there are a strong hierarchy of who's in charge and so forth. By us, literally, as I said before, by us being a team player and so forth, it was really noted by these people that have the higher positions. Felipe, which was the man in charge, he was a physio, and he was in charge of the whole the polyclinic for chiros, osteos, and physios. He came up to me in the end of the games and said, "Thank you for all the help you've been providing here, and I can see that you've been working hard to become a team player." So that's kind of nice. And I mean, it doesn't take much. I mean, help out with the day-to-day things like empty bins and clear tables, and just be available. If there was someone, sometimes we got people in and they didn't know literally how they got in, and they didn't know how to get out, and that could be a patient or an athlete from one of the physios. If you just were, if you were available, just help the athletes out again to the main area. I mean, small things like that made a huge difference. And when people see that you're trying and you try to be a team player, I think that's everything. On the picture, you will see me in the middle, and to my from when you're looking to the left, you will see a man named Edsel Bittencourt, who is a doctor of osteopathy and a master in physical therapy. He's the clinical director of Mayo Clinics in Jacksonville, Florida. Now, a cool thing happened. So I worked with Edsel for about 4 days, roughly, in the Olympic Polyclinic. And every patient, we took care of, both me and him. So we worked together on every patient. And I mean, the learning experience I had was just absolutely amazing. It was pretty cool to see someone with those skills and that understanding of human body in terms of performance and so forth. Just awesome. So it was brilliant to see the differences, obviously, there are between the professions and how we work and how we think. But a lot of times we literally came up with the same conclusion. The way we treated the person will obviously be different, because I'm a chiropractor and he's an osteo or a physio. So we still had the same thinking in the end, which was pretty cool. And he actually stood up for chiropractic. Now, the cool thing about how he did that was that there was a lecture for all the MDs from every country. He was invited to a lecture with Edsel. So everything from Russia and US and so many people there. I reckon a room maybe about 50 MDs. everyone was sitting down, obviously, and one of the first things Edsel said in there, he said, whoever in here that treats the side of pain should literally pack your bags and go home. And saying that to a bunch of MDs, I mean, I think that in Australian language you would say gobsmacked, which is literally like, you know, was down to your knees for some of them, which is pretty cool. I mean, he was so functional in his thinking, and he knew that most of the time that's not what where we have the problem. So that was pretty cool. So that's how he started the lecture. And about in the middle, towards the end, he said that we need to start working with other professions. And he said that I've worked along a chiropractor for the last 4 days. And it's been really, really cool. And we've shared a lot of experiences and helped a lot of athletes. And there was a couple of people that lifted their eyebrows a little bit more than others. And one said, why would we even need a chiropractor? What do they know? And Edsel said, well, considering that they are specialists in terms of being really good with spinal stuff, and they have a really good education. I mean, they do a lot of years in uni before they actually become a doctor of chiropractic. So he was literally just, you know, pushing for chiropractic as a profession. If I was part of that in terms of got him into that thinking over those 4 days, I don't know. But it was nice to see that someone from outside the profession was standing up for us. And it was quite brilliant, all the way up to the point where he said, well, we have one chiropractor with us today. I felt like sinking quite far down in that chair, but it was pretty cool. This picture is literally from just after that lecture. And the guy to the right then was the head medical for India, and he was super interested in chiropractic. And there was a couple of other countries as well that came up to me afterwards and were discussing literally, okay, so how can we get in contact with chiropractors in our country? So, I mean, small things, but in the end, I think they could mean a lot for our profession, which is cool. And just make sure that you think about everyone is listening. So when you're in a big room and you talk to patients and whatever, make sure you always stay humble and always stay positive. Because there's always going to be someone around any corner to look what you're doing, or listening to what you're saying. So just be clear about that. It's in an interesting environment, especially because we are under the loop, as I said, because IOC is still not 100% if they want chiropractors or not, and we just have to make sure that we stay on the good side. And in time, I'm 100% sure we will be in the Olympics. When that is, I don't know, but I hope it will be soon. All right, so the next page or next slide. This is literally the case that changed my view of Olympics. So we got a 17-year-old gymnast. Female, and she complains about dorsal midfoot pain. Duration about 6 months, insidious onset, aggravated by movement, especially after training, diffuse dull pain. The athlete did not report any prior trauma or any medications or long-term injuries. Family history was literally within normal limits. There was nothing out of the ordinary. However, she hadn't had any menstruation since she was 13 years old. She has to compete She literally came into me and said, I don't care whatever you do, just fix me because I need to compete and I need to reach the finals. And at that point, I thought that was kind of an odd way of talking. It's almost like she had the knife literally against her throat. So I said, so why do you, I mean, depending on what this is, which I don't know yet, I said, but when you say you have to compete, what do you mean? And sure, she didn't say this straight out, but it literally in the context we were in, she said, if I want my family to do well, I better reach the finals. And I mean, for me, that's it's kind of sad in a way, but I also know, I've also heard about there are certain countries or certain people that if they don't qualify for a certain thing, the support that their family in terms of money and food and so forth might be gone, or they will be tossed out from the team. And that does mean a lot for some people. I mean, I come from a privileged country where that would never happen. But I'm also humble enough to realize that there are countries where that stuff happens. So just by looking at that complaint, there should be some things that should make your thinking go into, okay, well, that doesn't sound too good. Especially when you talk about insidious onsets, especially when we talk about aggravated mind movement after training, having that diffuse dull pain that never seems to go away, and haven't had any prior trauma. If your red flags doesn't hit you here, I mean, this is a red flag case. So in terms of thinking, just take a small minute and just think about these few things that I've written. That pertinent information should give away quite a lot. But literally, that's the first part of my history taking. Because you want to just do any form of Socrates or whatever you use for analogy to find out what you want to do. But this is first part of my history taking. All right, so I hope you've made up your mind. So if you go to the next slide and we press again, and what's your working diagnosis? And now comes the drums, and press again. There we go. Ankle foot stress fracture. All right. So, funny enough, where do you think it is? I know many of you were sitting here now thinking about, okay, well, she got an ankle stress fracture. But what is common amongst people in terms of stress fracture? Which bone or which part of the foot would we often see this? So if you go to the next slide, I want you to think about a couple of things straight off the books. The course of action, obviously. So the picture on the right will give it away straight away. And the reason why I wanted to do that was literally to get everyone in gear. Because now you figured out it's a stress fracture, but what do you do from this point on? Especially important if you're in the Olympic Games and you make sure, you want to make sure that you know what you're doing and know what you're talking about. So if I say ask more questions, which ones? Things that should pop up in your window should obviously be medical history in terms of endocrinopathies, diabetes, thyroid, and if there are any autoimmune disorders, any gastrointestinal disorders, any psychiatric disorders in terms of depression or eating disorders. I mean, we're talking about a high-level athlete here that doesn't really want to put on any weight, because that's pretty important if you do gymnastics. So what I tend to go into a lot of times with these athletes is obviously dietary history. So in terms of, okay, so how much calcium, vitamin D, and protein do you take? Most athletes at that level tend to do a nutritional logs and training logs, which may be helpful in identifying any contributing factors. And obviously, you want to discuss any form of training, critical to examine any changes in volume, intensity, and type of activity. You want to talk about, okay, what type of surface do you train on? And if there's any change in equipment or any change in shoe wear, which will be very important. So those questions will become very, very super important when you start asking. Usually in patients with navicular stress fractures, you often see that the frequency is insidious. The patient often have difficulty describing the exact location. Most patients participate in activities and describing any form of that dull pain, diffuse, especially after training. And most of the time, we're talking about activities that require a fair amount of explosive movements. So sprinting, football people, gymnastics, basketball, and that types of track and field, that type of athlete, where you literally have to do a lot of that explosive movement patterns. You often want to talk about, obviously, or discuss with them when it comes to physical exam of the foot. I tend to go and look for the end spot most of the time. End spot is on the navicular, on the dorsal surface. I have a picture to show you a little bit later. But it's important to make sure that you're actually on the bone and not between the two tendons that come just next to that. So, and it is 81% of the cases, if you hit that navicular bone on the end spot and they jump, you kind of know that you're on the right track. Obviously, there are other things that you should be talking about in terms of physical exam, where you do any form of impingement thinking, so posterior tibial tendonitis or any midfoot structures. Percussion usually reproduces that pain for that type of injury. So you have to think about those terms as well, obviously, but if I hit the end spot and it's there, I kind of know what I'm dealing with most of the time. And if it's there's usually no swelling. People think sometimes there might be swelling in terms of stress fractures, but oftentimes, because they're not coming in with a fresh new injury, they have this for quite some time. You often never see any form of swelling unless it's literally has happened right then and there. There could be mild swelling, but it's not common. Obviously, any other tests you would do in terms of imaging, what do you think about? Do you think about MRI? Do you think about CT? Is there a difference? We will talk about more and going deeper into this down the track, but it is interesting to look at MRI and CT because they literally can be telling a very different story. But we'll come to that a little bit later. I usually also talk about what are the radiographic differential diagnosis of stress fracture, and most of the time people should know this. And we talk about osteoma, malignancy, or any chronic osteomyelitis. I think that's important to just have that with you regardless. Especially when you see the radiographic pictures, to just think about those three things. Do I see anything other than a stress fracture? If we go to the next slide. All right, so that's the end spot. And you can see, literally, it's between the extensor hallucis longus and the anterior tibial tendon. So what's important here is that if you are literally poking on one of the tendons, you might get a false positive. So just make sure that, and it's easy to follow. I mean, if you muscle test those two muscles, you can easily feel where those two tendons go in the foot, and just make sure you're literally in between the two. And if you do that, and you hit the end spot and it's elicited, then you kind of know that you're on the right track, especially for navicular stress fractures. All right, so on the next slide, we talk about low risk fractures and high risk ones. If you get the text up, Christine. Now, the definition of a stress fracture. A type of stress fracture due to abnormal stresses on normal bone, aka fatigue fracture, must not be confused with insufficiency fracture, which occurs on normal stresses on abnormal bone, osteoporosis. So we're not often dealing with any problem with osteoporosis or osteopenia. We are dealing with abnormal stress on normal bone though, and that's where we end up with a fatigue fracture, which is the common one in terms of what athletes get. Sure, some of them obviously might be osteopenic depending on how the nutrition is, but that you can see in the nutritional logs, and that you kind of can look for in that sense. But it's important to think about when you're dealing with stress fractures, that most of the time we're not dealing with osteoporosis or osteopenia. All right, so if we go to the next one, Christine, we talk about low risk fractures, stress fractures versus high risk. So to the picture to your right, there you will see the low ones and you will see the high ones. The low ones you can read. I won't go through them, but if you look at the high risk one, which the anterior tibial diaphysis, the medial malleolus, the navicular, the base on the second metatarsal, the proximal fifth metatarsal, the talus of the great toe, and the sesamoids. Reason why they are high risk is usually due to poor blood supply, a lot of shearing forces through the surface and their location. So when you're dealing with the high risk ones, that may have to make you think slightly different, because they're gonna obviously take longer time to heal, and we're gonna talk about risk of things like malunion and insufficiency and so forth. So it's quite important to think about those two in particular when we talk about navicular stress fractures. On the next slide, as you see, when we talk about mechanical stresses versus repair, so the balance between damage to the bone, which is the load, and ability to repair. That's literally what we talk about when we see these fractures. So obviously her ability to repair hasn't been enough to support that load that she's putting her body through. And we got to think about, when I say don't forget the etiology of stress fractures is usually multifactorial. It's usually not depending on one thing. So we talk about the intrinsic factors and we talk about the extrinsic factors. So when we talk about intrinsic factors, we obviously talk about things like biomechanical features, pes cavus, metatarsus adductors, if they have limited subtalar or ankle motion, medial narrowing of the talonavicular joint, a short first metatarsal, and potentially in some research I've seen that the os supranavicular could be thought in there. Metabolic conditions, obviously menstrual patterns, level of fitness, muscular strength, endurance, and vascularity. Extrinsic factors, obviously stuff that's not inside the body but outside. So we talk about exercise pattern, we talk about equipment, we talk about nutrition. So those things, which goes pretty quick when you do your history taking, it goes pretty quick to go through all those things. History and obviously your physical exam. It shouldn't take long to go through the intrinsic and extrinsic factors. And if you have them back in your mind, you can literally look for these things. I mean, limited subtalar ankle motion is a risk factor. So I think it's important to remember that what we can do to our patients can be quite a lot in terms of helping them to reduce that load on specific bones. What we do obviously is in this case can be to help the patient make them less prone for injury in terms of stress fracture. This athlete though, regardless of what I would have done to that foot, she would still have that stress fracture. So what can I do to help her through that stress fracture or making sure that she can actually compete? That is not easy, first of all. And second of all, when we talk about, okay, how much do you dare to adjust around a stress fracture? I tend to go above and below. I usually don't go on the specific site. You might just inflame it or irritate it more. So be kind of cautious in what you do and think about it both once and twice. You are at the Olympics and you are in a seat that you don't want to maybe make someone worse than better. So you have the opportunity to instead get them to come back even multiple times a day. And then you can recheck and check them again. So just be smart about it. We don't have to fix them in one treatment. We can actually fix them in 20, especially because it doesn't cost them anything to come in. When in terms of the athlete's ability to heal microfractures, which is literally what it is, obviously is going to be affected by specific anatomy of the bone, as well as the overall metabolic status of the individual. And that could be literally from affected by hormone imbalances, sleep deprivation, nutrition intake, obviously, any chronic conditions. It could also be there, and if they have any, collagen disorders or anything like that. In females, the estrogen deficient state often leads to a decreased bone density, which we know from research. Borrow and Saha in 1988 found that menstrual irregularities correlated with an increase in stress fractures in female runners. Additionally, they show that women who with more than irregular menstruations, particularly those with 5 or fewer cycles per year, were found to have significant higher incidence in stress fractures. The term female athlete triad was first described in 1993, refers to a combination of eating disorders, so dietary restraints, which is not too common, amenorrhea, and a low bone mineral density. And it has been as high in terms of stress fractures with a risk of up to 30 to 50% in those individuals. So, I mean, if you have a female that might have dietary restraints and she's 17 and haven't had any menstrual cycles since she was 13, I mean, that female athlete triad is definitely important to think about when dealing with an athlete like that. If we go to the next slide, we'll talk about different sports. So obviously runners are, we see a lot of runners because they're prone to stress fracture in the posterior medial tibia, distal fibula, and navicular. And we see dancers commonly have stress fractures on the metatarsals, including metatarsal bones and anterior tibia. Jumping activities such as basketball can lead to stress fractures in the anterior tibia and calcaneus. And the last one, which I find kind of interesting here, track and field athletes account to 59% of all navicular stress fractures. I mean, that's huge. So I mean, Christine, that's something you would like. Wow, that's crazy.
Exactly.
So I mean, just thinking about that, 59%. So if you have a track and field, and they come in with a lot of those symptoms that we've gone through so far, you got to think about navicular stress fractures. It is that common. All right. So the next slide. Here are the stress fracture classification. So Saxena has classified this, Saxena et al. And I got to say, all the research in terms of navicular stress fractures, this is definitely the best I've come across so far. And the interesting here, as you see, 0.5. So there's a 0.5, there's a 1, there's a 2, and then there's a 3. 0.5 signal change on MRI noted, but stress fracture not imaged on CT. So if we're dealing with the 0.5 stress reaction, you cannot see it on an CT. However, CTs are often used in terms of visualization of the actual fracture. So often you will see that people do an MRI first, where we obviously look for bone edema and so forth, either a fat set or a stir. And the reason why often we want to do a MRI first is because we want to see if it's a 0.5. We do not want to miss it if it is, because that could be really tough for the patient later on and saying, well, you got no stress fractures, so that's good, and let them continue playing or do their sport. And then a couple of months later, we actually have a much worse case than we could have prevented in the first thing. So that's why we do the MRI. The CT is obviously when we come into the 1, 2, and 3 grade or type, where you need to visualize the fracture itself to see exactly where it is, because that will tell you obviously which grade it is, and sometimes also if surgery is needed or not. Next slide. Would you like to take us through this, Christine? What are we actually looking at here?
Okay, in this view here, we're looking at the different types of navicular stress fractures, just so we're kind of getting an axial view. So we're looking from the top down here. You can see the arrow in box A on the navicular, so that would be your type 1. And, you know, kind of getting a gauge for the different types of stress fractures is significant, and that it also speaks to severity. And when we're talking about, you know, can somebody participate in the Olympics, as Martin was saying, we've got to understand, is this a partial stress fracture? Is it a 0.5 stress reaction? Or are we talking about, you know, the complete, the type 3, which is the complete cortical break? So understanding your types of stress fractures is significant in knowing, can we return to sport? Can this athlete get to the finals today? So if we look at A again, we see type 1, and that's just where the arrow is pointing to. That's our cortical break there. Type B, I'm sorry, on the top right, is actually extends to the navicular body. So you can see how that fracture kind of encompasses. And if you can see the white sclerotic margin, that's the reaction. So that speaks to the amount of time that this has been trying to compensate. So for lack of a better term, a compensatory pattern. So this athlete has been dealing with this for a period of time in B, and the body is trying to metabolically turn over, but not doing a good job at it. So when we see something like this, and this is a long-term thing, you know, again, we have to speak to, you know, the amenorrhea, osteoporosis, and osteopenia, you know, that female triad Martin was talking about, and see if, you know, we have insufficiency metabolically to turn over that bone to heal. So sometimes looking at these MRI images can speak to why it's happening too. Now, if we look at C, right here, that's our type 2. That's a less common stress fracture. But again, looking at it looks a little more deep-seated. And we can also see that the body has been attempting to form a sclerotic margin and trying to contribute to that metabolic turnover, and not doing a good job. And a question here for somebody in this BC area is, have you been masking these symptoms with Advil or NSAIDs prior to practice or after practice? Because we know that that type of a care, if you want to call it care, will actually stop the turnover of new bone cells, right? So we're stopping the osteoclasts from forming, and we're actually not able to get those osteoblasts up and running so that we can get good bone turnover. So asking questions like that too, and of course the vitamin D is a huge one as well. And then in slide D here on the bottom right, we can see that type 3, and that's your complete cortical break. And the classification is it has to go from one cortex to the other. And of course, something like this would be what I call a no-go, or a high risk for a complete fracture as soon as this athlete steps back out onto the mat to compete. So it would be something that would be preclude them from returning to sport, a very high incidence, and I would defer to the orthopedist for consult on that. Okay, Martin.
Cool. And the next slide, we'll see then, obviously the 0.5, where we have the stress reaction. And we can note here is obviously lack of cortical break. So that's why it's important, in my perspective, to do an MRI first. And most research suggests the same thing. Make sure you do your MRI first before you head into CT. Sure, it can be a cheaper option with CT and an easier option a lot of times to get referral for. But research does not push us that way. It literally pushes, okay, do your MRI first. Once you have done that and you can see there is a cortical break or not, or if there's just a stress reaction or anything else, then you do your CTs to get a good visualization on that fracture to really know what you're dealing with.
Yeah, that MRI is 100% sensitive for navicular stress fractures. So, and it has good resolution as well. But I just wanted to make a quick comment about the location of stress fracture commonly in these navicular stress fractures being the middle 1/3 of the navicular, and that's the area of avascularization that anterior and posterior tibial arteries are not adequately feeding. So when you bring up your T2 image, and we can look at A, and that's your axial view, we can see that area that's kind of lit up. That's that area of edema, and that's why I like that T2 image. That's kind of my cheat on that navicular there, and so we can see that that's that middle 1/3 of the navicular. So it's highly suspicious then that that's that zone of avascularization, or what I call a white zone, where they're not getting good blood flow and they're not getting good metabolic turnover. So the chances of that progressing to a type 1, 2, 3 stress fracture are very high.
And actually in the next slide, we actually go through a little bit of this avascularity, which is kind of interesting when you go through the research in this. Because, I mean, before I literally delved into all the research in terms of navicular stress fractures, I did know about the middle third of the bone, and most of the research I read previously back in uni and so forth, they were talking about, right, that poor blood supply, etc., etc., etc. And it's interesting when you read the research on this, because the zone of vascularity in central third of the bone was first described by Vaughan in 1958. And it's funny, with most research after that, people tend to look back in previous, obviously, research and saying, well, yeah, he said it first, obviously it has to be right, because that's how you think. But when you read his research, which I have, you would know that he actually did his study on pediatric population. So he did his, literally he had not even that many. I think it was, I can't remember, it was 20 or 200, but it wasn't that many that you would like, whoa, that's a lot of people. And they were literally between 1 year of age to 19. And we do know that, I mean, we do grow a fair bit of our life, and stuff like that can change. So 2012, McKinnon et al. Did not find a central zone of vascularity in 86.7% of cases. Did he find, obviously, not well vascularized naviculars a lot of times? Yes, he did. But did he see it in that central portion that was been like literally been quoted so many times before or cited so many times before? No, he didn't. So it's kind of interesting, and he obviously didn't do it on a pediatric population. He did it on slightly older individuals between 20 and 40. So it's interesting to see that there might be a difference here. And that I know that there are other people that have been looking at this as well. But in terms of good research, I would say McKinnon did a pretty good study in terms of how he methods and so forth. But it's a good study, and I have it in the back of the slideshow, and you can have a look at it and read it.
And I guess a good question I would have would be, how does that vascularity change from the pediatric population to that 20 to 40 population? And is that why these two researchers have such a different opinion?
Yeah, I would think that maybe it has to do with load. I mean, we go through life, and stress on the bone obviously going to change the bone, and load in terms of that, gravity and so forth, and what we do might actually completely change the way we have vascularization to certain parts of your body. That's my thought about why that might be the issue. But I mean, even McKinnon in his research, he doesn't actually know why that would be the case. So I mean, there's obviously, if someone out there wants to do some more research, I mean, that's a good, that's a good study right there. And obviously, if you go to the next, you'll see that Mendel et al. 2017 concluded from the current research that the avascular area of the navicular is potential cause of navicular stress fractures. And who did he cite? Obviously, someone from 1958. So, I mean, you'll see it in new research, and they cite it, you know, all the way down to Vaughan. So, as I said before, maybe it is the biomechanics, the load. That's more or less the reason why we see this in athletes. It's a good question. I mean, will we find out in the next few years? Probably not. But I think it's important to think about, at least from that point on, that we might be dealing with someone that just having the ability to repair that much needed for that load they're actually putting through their body, especially then if they're not particularly good with their nutrition and a couple of other things. So it's important to remember that. Biomechanically, the foot can be divided obviously into different parallel columns, a rigid lateral column and a more flexible medial column. The medial column, though, is comprised of talus, navicular, and the three cuneiforms. And the lateral consists of the calcaneus and cuboid, and the fourth and the fifth metatarsals. The tarsal navicular is considered the keystone of the medial column, as most of you already know. And numerous passive and active restraints stabilize the medial column at the talonavicular joint, including the calcaneonavicular, the spring ligament, as well as the posterior tibial tendon. But it's interesting to see when they've done a couple of interesting biomechanical studies on how the navicular actually is working underneath stress. And because we know it actually rotates its way around. So if we have one stable surface and you have navicular in the middle and then you have the talus in behind, it actually rotates like this. And when you think about that through a running step then, and you actually rotate it at the same time, I think that if you have that increased load, then it makes sense to me why it also might be the central 1/3 that would be the injured part, because the force has to go somewhere right in that step. And the only way, the way I see it, because I mean, if you look at the navicular, it's not a long elongated bone. It actually sits across the foot. which means that where would you have the most stress? It's almost like taking a tea towel in both ends, and you do literally like Chinese burns. Where do you have the most part of that towel to be most stretched or rotated? Obviously in the middle. So I think that's how I think about it, and I think that might be the cause why we see navicular stress fractures, specifically one in the central 1/3. If you go to the next slide. So when it comes to surgery versus conservative care, I mean, if we talk about in a non-displaced partial fracture, conservative treatment have been shown to result in return to sport in 5.6 months in 80% of patients. So that's pretty cool. I mean, if we can go without surgery, I think that's great. If we can't, I mean, then it's surgery, and obviously that's the right way to go. What we have to think about though is any form of non-operative treatment typically includes a non-weight bearing short leg cast for 6 to 8 weeks. That is not optional. In my opinion, 100% from all the research that's being produced here, everyone literally says the same. So short leg cast 6 to 8 weeks. Did I put this athlete in the Olympic Games in a short leg cast for 6 to 8 weeks? And no, I did not. And why didn't I? Literally because, as you all remember, she came up to me and said, I'm going to compete regardless of what you do, but can you make it better? So I mean, regardless of what I would have said that day, she would have competed. If my help or not, she would have done it. So then it's all about trying to obviously help her as much as I can. Conservative treatment research has shown that return to activity in non-displaced partial fractures is obviously 4.1 to 5.6 months. That's pretty cool. Surgical intervention though, we talk about internal fixation, open reduction internal fixation, with or without bone grafting, is 2.6 to 5.2. And often we see this, I gotta say often, we see actually shorter period of athletes being away from their sports in terms of surgery. So surgery tends to fix it a little bit quicker. But obviously, once we've been in there, once we've gone into the joint itself and start doing stuff, we gotta think about later down the track when we talk about arthritis and so forth, osteoarthritis. So we do know that the degenerative changes goes pretty quick as soon as we've done surgery. If I'm not from memory, I think we talk about 4 times this pace of degenerative changes once you've been actually into the joint itself. So it might be a quick one to do a surgical intervention, and you might be back quicker or sooner. But that's a discussion you're gonna have to have with your athletes. Usually when we talk about athletes getting a navicular stress fractures, we do tend to say, well, that's probably that season. So that it is a very serious injury itself. So we've got to keep that in mind. Obviously, one complication of a navicular stress fractures is avascular necrosis, which may necessitate bone grafting. And obviously malunion is one of those as well. So we've got to have that in mind when we look at, and it comes back to what you talked about before, Christine, in terms of, okay, what type of fracture is it? So are we talking about type 2 and 3? Most research do suggest that we should look at a surgical intervention on that. So surgery also recommended when the fracture is displaced or demonstrate any form of sclerotic margins or cystic changes on a CT. If the athlete has failed conservative care, that's also a good one to throw in there. And surgery may be considered in some circumstances in which the athlete has an upcoming season and early rehabilitation is imperative. So if that's the case and they really need to be on the pitch or a field or whatever, often you will see that they will go for a surgery. On the next slide, some research has obviously shown no difference in return to activity in either groups, which is interesting. However, the risk of refracture when we talk about the conservative treatment group here is 11.2%. And that we do not find that in the surgery group. So that's important to also remember that if they continue doing what they're doing and not making maybe any changes necessary to be having a better health or thinking about how they actually compete, sometimes we do have to change a technique on either how they run or how they do certain things, and that will actually do a lot in terms of load. So we got to have that with us and look at that. Just because they're an Olympic athlete doesn't necessarily mean that they have the absolute perfect technique in anything. So a lot of times if you talk to their coach and you talk to them about, okay, this is what I see, this is what I think is going on. Have you seen anything in this and this and that in terms of how the athlete is running, how they're pushing off? Sometimes it helps to videotape them or film them in certain positions. Just get them to do a box jump or whatever to see literally how is their strategy of doing that simple activity and without weights, without anything, without force, to try to visualize, okay, what will then happen if you do 50 flips and this ankle is pushed every single time. So it's important, and I know you work quite a lot with gymnasts, Christine, and I'm pretty sure that you do a pretty rigorous before the season starts to look at them and look at their both equipment and how they jump and what they do and so forth.
That's exactly right. We do a lot of landing technique skills, video analysis of that, because we do see a lot of this type of stuff in gymnasts in particular. Yeah. So in the preseason, we'll take a look at them, their ability to kind of work through their foot as they land, so to speak, to have that foot be more of a shock absorber as opposed to a shock absorber, just whether it's resilient or not resilient. So we do that, and we retrain them so that they have a more successful return to sport.
Exactly.
Yeah.
And I mean that in my world, if you're a sports caro and you really want to work with these type of athletes, you got to think in those ways and start upping your game in that and start videotaping because it becomes so important to making sure that you're early on and catch these things as quick as possible, so it doesn't become an issue for them later. I mean, as I said before, one season of sports is typically lost. And that's kind of sad if it could have been prevented. And the last thing there is weight-bearing treatments were all inferior in all the outcome measures according to all our research up to date. So, I mean, if you don't think that they need a short leg cast, please think again, because I gotta say, I would not, no one of my athletes would be able to walk out in my office and not knowing that I'm 100% for those 6 to 8 weeks non-weight bearing. Can they do different other exercises? Of course. I mean, they have an upper body they can train. They could even go and jump into water and be completely still with their lower body and just use their upper body. There are things that they can use to work on that. So they can do training It's just that it is 6 to 8 weeks non-weight bearing. All right, so the next slide. What is our role as a chiropractor? Now, now we come back again to the athlete that I was treating. So in terms of knowing then, from all we know now, which should be a fair amount of stuff that you've learned, what would you actually do in terms of treatment and information? So obviously the education that I gave her, I made sure that obviously we had an MRI, which is kind of sweet when you're Olympics, because you can literally just walk down the hallway and there's an MRI, and just put them, okay, well, you sit here, and once you get the which is about an hour later, you get a full report from the radiologist. And you can read the report, and usually you have the if you have the chance, you can even go through the radiographic pictures with him in his office, and you look at them, and he goes through everything what he sees, which is brilliant. Now, when I did this MRI, or before I could do this MRI, obviously the MD has to sign off it, and the MD was hesitant. Do not ask me why. She was just very hesitant why this athlete should need an MRI. And I convinced her, and I said, well, we got to exclude a stress fracture. If there's anything we need to do, it's that. I said, you can do whatever you like to do with me later. I'm happy with that if you don't send me anything, but I just would feel a lot better if we did this MRI. So we had the MRI, and obviously we saw the navicular stress fracture. Now, the cool thing with her, though, was that she only had a 0.5. So we caught it really, really early, which felt really good. Now, obviously, I would still like her to be in the short leg cast, which I obviously couldn't. So, and I tried to talk her into bringing a coach, but that didn't happen. She was not interested, and I'm pretty sure she'd never told anyone about this. What kind of information is obviously then important to our athletes? If I would have seen a different radiographic picture where we might talk about a type 2 or type 3, because I got to tell you also, you cannot know what type it is. A lot of times the symptoms that you think would correlate to type 2 or type 3 does not do that. So you can have symptoms equally bad for a 0.5 as a type 3. So that's important to remember. You cannot by symptoms think that you know, which means that you have to know with imaging. And because if it is a type 2 and if it's a type 3, and non-union is high risk, avascular necrosis with bone graft also high risk. And we do not want that. So make sure that you talk to your athletes in the way that they understand the seriousness of the injury. And I made sure to talk to her about her 0.5. And I said, well, what I can do for you is literally try to tape you as much as you can, but you gotta stay off that foot as much as you absolutely can for the next few days until you actually have your semifinals. So she was in the semifinals, but needed to go to the finals. So what actually happened was that I taped her, I worked on her, I taped her. She came in the morning after. She had been obviously off the foot the whole day, and that day she had the final or the semifinal that night. So obviously I retaped her again, making sure that tape would do really well. I used kinesio, if I'm not remembering, I remember, kinesio, and then I had rigid tape on top of that. Because I wanted to get as much feedback as I could. At the same time, I wanted to lock that ankle down as much as I could. So even though a short leg cast is a different thing, I tried to, as much as my ability, create some form of stability for her. And she did make it to finals, which is pretty cool. She she had the finals a couple of days after. She wasn't sure though if she would actually compete in the finals. She said, I'll probably just go home. So I don't know if she competed. I didn't see her name actually in the final as a competitor, so I'm pretty sure she just went home. But she managed to come to the finals, which was her goal, and that's what she needed. She was only 17, so obviously she has a few years left to do that, and it would be cool to see her again in different Olympics if I ever get a chance to go again. And what I also talked to her about was that she obviously needs to find someone in her home country that works with her. And I said, great if you can find a chiropractor, but I would also like you to work with physios. I would also like you to work with other healthcare professionals, so you can get as much as possible in terms of education and knowledge and help during this time, because I said you got to take care of your body. If you want to compete later on, you got to start now taking care of your body. It's not good enough that you're here now in the Olympics and actually are injured. That shouldn't happen. So obviously your training regime is not matching up with the other things, and you need to have a discussion with your coach about that when you're feeling better, or you can. And you also need to obviously include other health professionals to help you with a good road back through rehab and so forth, and to become stronger in that body and do better. If we go to the next slide. Oh yeah, to the last one, what interventions, we can actually go back to them, Christine. What interventions could help improve her outcomes? Obviously, the short leg cast will definitely help her improve her outcomes, 100%. You can do some patients, athletes have actually responded quite well to some stim. So electrical stim is quite nice. They feel better when they do it. And I work with a couple of physios, and they actually send them home with a stim device, and they actually do it in themselves. And that tends to, they sit themselves, it feels really nice. And we see return to activity quite soon, most of the time in the conservative group. So I do like to use that. I talk to the patient obviously to use, if they want to, they can use hot and cold if they have any pain, and so forth. And sometimes that actually helps. So a warm foot bath and a cold foot bath can make a difference. Other interventions that could work is obviously soft tissue in their lower limb. So I often want to go through their calf muscles, go through both anterior and posterior, obviously. The peroneals might be even some tightness to them as well. So you can work through the muscle groups. Usually you'll see that the hamstring tends to be quite pissed off. I think that has just to do with how you change the way you walk, or how they change the way you run and so forth, how you put load on that leg. And obviously you will definitely want to check her spine, wherever you might deem most appropriate. Often, obviously, you will see issues in her pelvis. And do not forget the pelvis actually has an anterior side to it. So the anterior side of the pelvis is equally important as the posterior side. That tends to do a lot of help for these athletes. If you go to the next slide. The take-home message. Obviously, exceptional history taking will help you score 95% of these ones straight off the bat. The covering the intrinsic and extrinsic factors will definitely support your thinking from the beginning. Obviously, the end spot, as I said, 81% of patients do respond to tenderness to palpation and percussion there. Do your MRI or the STIR or the T2 and look for that bone edema. CT is obviously recommended for allowing the best characterization of the fracture. So once you've done your MRI and you see that type 1, 2, or 3, then a CT is warranted. And And the next slide. Let's see. Yeah. And short leg cast, obviously, for 6 to 8 weeks. Now, non-displaced or displaced fractures with sclerotic margins, patients who fail conservative treatment, or patients who cannot tolerate long periods of conservative treatment, surgical option is warranted. So that's very important. As Christine said before, anti-inflammatory medications may delay bone healing and are not recommended, mostly because they clash with the osteoclast itself, and that is definitely not something that we want. I usually tend to recommend some calcium and vitamin D supplementation. Do I have solid evidence of that? No, I do not. But in terms of what we know about bone and how bone is created, I think we could fairly say that it might be optimal for that athletes, depending on their nutritional logs and so forth. So definitely keep it with you. And the last one, co-manage the patient athlete with other healthcare professions. I mean, I think that's super important, especially if you work as a sports chiro and you want to be inclusive and you want to be transparent in what you do. I mean, do work with other healthcare professions. I mean, they will refer you patients later on, and help, where you can help a lot more by just being that person. So do work with them, and make sure that you think of yourself as a team player. Then the next slide, we talk about obviously the references of all this stuff, which is 2 slides, and definitely have a read if you find this interesting. And apply to Olympic Games. If you get the chance, definitely apply. It is definitely not glamorous, I gotta say. It is really hard work. Is it worth it? I mean, for me, it's worth everything. So if I could do it again and again and again, and I had to do everything that we did without a heartbeat. I mean, sure, it's hard work, long hours, up early and so forth, but the experience and the people you meet and the things you learn, I mean, I've probably learned more on all the events I've ever done than I've ever done on any seminar. So how did I get to that point? Obviously, taking our ICSC we have in FICS and then go to the FICS events. That's literally how easy it is. And I think in the future, hopefully one day, FICS will have a written contract with the IOC, and then we will also have chiropractors on every single Olympic Games. It is in the making. The question is not if, the question is when. So that's, I think personally, is pretty cool. And the last image is actually me and Ulrich standing in front of the Olympic rings in the Olympic Village on one of the days. It was super fun to work with Ulrich, and we had a lot of cool moments during the games. And we also got a chance to get free tickets to go and see one of the events one night. I think it was, if I'm not mistaken, I think I saw Usain Bolt run the 200-meter semifinal, which was pretty cool. We sat so close. I mean, you could. It felt like you literally was down there. And once you've seen these guys run, I mean, you think it goes quick on TV. It's nothing in the real world. They are so fast. Wow. I was so impressed. I was super impressed. So it's pretty cool to see some cool athletes running and a lot of other things, obviously, but it's definitely worth that. It was tough the day after, because I don't think we got home until like 1 o'clock in the morning, because it was absolutely so far away from where we stayed. But 3 hours later, we were up, a couple of extra coffees that morning, but you know, it's all good. So thank you very much for allowing me to have this webinar. I hope you found it to be very interesting, and maybe hopefully you learned something, and hopefully you also apply next time there is Olympic Games around. You have any questions, Christine?
No, Martin, I wanted to thank you for doing this lecture and sharing this great experience with us, and all the learners that have gotten onto this module. But really, the interesting thing I take away from this whole lecture that you gave is how when you do these events, sometimes you take time away from your practice, which is a financial hit a little bit, but look what you come away with. You really grow as a professional. You learn not only content, which is your stress fracture investigation, but also on how to work with a team of different healthcare professionals. So I find, we worked events together in the past, and with all your experiences at different events, I think each time you work an event, you grow in a different way and become just a little bit better each time when you go back to your practice. Do you agree with that?
100%.
Yeah.
100%. I mean, it's funny, you always have something that you want to test when you come back to practice. You've seen something, someone did something, or you just, I mean, we often take time to learn from each other when we're at these events.
Yeah.
I mean, you will always come back filled with passion, enthusiasm, and interest, and doing the best you can possibly do for your athletes or patients.
I agree. I agree. All right. So thank you so much for your time. That was just really super informative and great information. I appreciate all your research.
Thank you
Have a
very
good
much. See you guys.